Welcome everyone to Epilepsy 101. My name is Kathy Fiskus. I am the operations coordinator for PMSF. We have a great session today, and it is my pleasure to introduce our guest moderator, Dr. Grabensdatter. She is the Science Director of International Foundation for CDKL5 Research, a member of PMSF's Board of Directors, and a strong advocate for epilepsy and rare disease research in our community. Welcome, Heidi.
Welcome, everyone. It's my honor today to stand in for Dr. Kate Still. It's unfortunate we can't have her here with us, but we are glad to have Dr. Jimmy Holder here to talk to us about seizures and PMS. I want you to know a little bit about Dr. Holder, who is an assistant professor in pediatrics with the Neurology and Developmental Neuroscience Department at Baylor and Texas Children's Hospital. He has extensive training in child neurology and has established a synaptopathy clinic, that's a hard one for me to say, to care for children with neurological disorders with variants in genes critical for synapse function. Part of his research mission is to identify therapeutics that increase the functioning of neurons when SHANK3 is not functioning correctly. Dr. Holder has been a long-term advocate in the PMS community for approximately a decade now and has contributed to many research studies and publications in Phelan-McDermid syndrome, and has played an active role in prior conferences, so you are familiar with him, and it is an active member in the PMS Echo Neuropsychiatric Consult Group.
Okay, perfect. Thank you. All right, well, thank you so much for that introduction. I feel my job today is really to provide information about what epilepsy and seizures are in general. And this is, really going to be directed to new families, new parents who maybe haven't thought about this either because this is a new diagnosis of Phelan-McDermid syndrome, perhaps an older diagnosis of Phelan-McDermid syndrome where seizures have just become an issue. And then I'll provide some specific information about seizures and epilepsy and Phelan-McDermid syndrome. So to begin with, I'm going to tell you about some of the objectives we have today. First, I'm going to define seizures and epilepsy for you and present some examples of different types of seizures. So not all seizures look alike. And sometimes that's one of the harder things to know about because we might all have some preconceived notion of what a seizure should look like, but seizures can really look very different in different people or in the same person at a different time. I'll describe broadly describe some of the treatments for epilepsy and then describe some of the life-threatening complications of seizures. Then I'll go into a review of some of the literature of Phelan-McDermid syndrome with regards to epilepsy. And then describe our experience at Texas Children's Hospital of epilepsy and Phelan-McDermid syndrome. Talk about a study that reported the utility of long-term EEG in Phelan-McDermid syndrome. And then at the end, discuss what we know about the genetics of epilepsy and Phelan-McDermid syndrome. So some basic definitions. So what is a seizure? A seizure is a transient disruption of brain function due to abnormal and excessive electrical discharges in brain cells. So, that may not be exactly clear as to what you should look for in your child in terms of a seizure. And I'll go through some examples of what you can look for. So what's the difference between seizure and epilepsy? Epilepsy simply means more than one unprovoked seizure in an individual. A provoked seizure means something like an individual has a strike to the head and has a seizure following that strike. An individual who might have had a stroke and then has a seizure right after that, that would be a provoked seizure. So an unprovoked seizure is one that really comes completely out of the blue. EEG, or electroencephalography, is a brainwave test. This is a test where we look for signs of either seizure activity itself or predisposition to seizure activity. And I'll describe a bit more what an EEG looks like in a couple of slides. Then MRI, or magnetic resonance imaging. This is an imaging technique that we use to look at the structure of the brain. And this is something, as I'll describe next, that we do for all kids that have a first-time seizure to determine if there is a structural abnormality leading to seizures. So what do we do for a child who has a first-time seizure? Every child with a first-time seizure should have an outpatient EEG. Again, this brainwave test looking for signs of either irritability, brain irritability that could predispose to seizures, or frank seizures themselves. And this can help in guiding our deciding what therapy might be best for an individual. An outpatient MRI, again, here we're looking for those structural changes in the brain that could be causing seizures. And sometimes this can direct how we approach seizures in an individual. And then if a child has had more than one unprovoked seizure, we usually recommend medication as the first line of treatment for seizures. And I'll go through some examples of the different types of medication that can be used for seizures in Phelan-McDermid syndrome. So what can seizures look like? Well, they can look like a lot of different things. So the first I'll describe are absence seizures. These are brief staring spells. They typically last 10 to 15 seconds or so and can be associated with or without stereotypies. Stereotypies are small motor movements that can look like a lot of different things. They can look like lip smacking, eye blinking. I'll show you an example where it manifests as picking at clothing. But basically small, repetitive motor movements. Seizures can also be complex partial. This is can also initially look like a staring spell. Usually these last longer, up to between 30 seconds and up to several minutes, but can also evolve from a staring spell to appear as either eye deviation, that is eyes or head moving in one direction or another. I'll show you an example where a complex partial seizure manifests as kind of a more complex motor movement. And then these can evolve into generalized seizures. Atonic seizures, also known as drop attacks. This is where there's a sudden loss of tone. This really typically lasts just a second or even less than a second. And can be very subtle. These can appear just as a subtle head nod, or can be complete loss of tone of the head and torso, and I'll show you an example of that in a minute. Atonic seizures, although they're very brief, can actually be quite devastating because with that complete loss of tone, if the child is in the wrong position, can lead to significant injury. A tonic seizure is characterized by general increase in tone without clonic movements, so sudden stiffening, but no rhythmic movements. Generalized tonic-clonic seizures are what everyone is kind of more familiar with in terms of grand mal seizures. These usually begin with a generalized increase in tone, so sudden increase, a sudden stiffening, followed by clonic rhythmic movements. And then myoclonic seizures are also sudden movements, but these are a bit milder than the rhythmic clonic movements of generalized tonic-clonic seizures, and usually are not rhythmic. And I'll show you an example of that in a minute. So first example here is of a child with absence epilepsy, having an absence seizure. So what you'll see in this video is a child who's purposefully breathing in and out very fast, so hyperventilating. And for generalized, for childhood absence epilepsy, this is a known trigger to induce a seizure. So again, what you'll see is this child breathing in and out quickly with her eyes closed, and then suddenly her hands will fall down and you'll see her begin to pick at her clothing, and that's when she's having the seizure. So I'll start the video here. Again, you can see her breathing in and out fast. Hands are up just so that we can see she's not having a seizure. And then when they go down here, now she's having a seizure. You'll notice mouth movements and a little bit of picking there that kind of progresses to more picking at her clothes. So all during this time, she's having a seizure. It'll last about 20 seconds or so. And then you'll see her head suddenly come up and she's answering person off screen. So that's when the seizure ends. So again, seizures can be very subtle. If you didn't see the entire event, you might not even realize this child was having a seizure. And I apologize, some of these are very old videos, but this is an example of a complex partial seizure. So it begins just very briefly with a staring episode, but it quickly evolves into a complex motor movement that you'll see. So that's when the seizure starts. And you can see what we call bicycling of her lower extremities. So kind of rhythmic movement. And you'll also notice her eyes are moving towards the left, towards her left, as well as her head. So that's that head deviation, eye deviation I was talking about. Again, this seizure lasts about 30 seconds or so. And kind of a big breath in there. And she's going to be out of it now. So now she's kind of back to herself. And interacting with her mom again. Okay, next example is an example of an atonic or drop seizure. So again, this is a sudden loss of tone. So you'll notice this child is just playing, interacting with her mother, and then suddenly fall to the bed. So that's the sudden loss of tone, and she's right back to her normal self within a second after that. So you can see why, although in this case, of course, she was in a safe environment where she did not get hurt, someone walking up and down the stairs having one of these events could get significantly injured. And then the last example I'll give you is a video of an individual having myoclonic seizures. So here you'll see motor movements that are not really rhythmic. They're really fairly random. This individual is actually having generalized myoclonic seizures affecting both sides of the body, but myoclonic seizures can affect just one side of the body. So I'll start the video. So you can see sudden movement of the arms and sometimes of the legs. It's involving both sides. I should mention, I didn't mention this at the beginning, but none of these individuals have Phelan-McDermid syndrome. These are just some stock videos that we have of different types of seizures. All right, so we're going to move on now from defining what seizures are and showing you examples of them to talking about treatments for epilepsy. And as we go through this, I'm not promoting one type of medication for seizures or one type of treatment for seizures in Phelan-McDermid syndrome versus another. As we'll talk about a little bit later today, there really is not any good data to support one treatment over another for seizures in Phelan-McDermid syndrome. These are just to give you some general ideas of what medications are used. So for those partial onset seizures that I showed you earlier, these are seizures that begin really just in one part of the brain. And although they can generalize to involve both, or to involve all areas of the brain and involve, evolve into a generalized seizure, when they begin in one focus, one area of the brain, we usually begin with medications that are fairly specific for these partial onset seizures. And these are voltage-gated sodium channel inhibitors. There are quite a number of different types. Some of these are pure voltage-gated sodium channel inhibitors. Some of them have other mechanisms of action and can actually be used for other types of seizures. You can see here a list of the various types of sodium channel inhibitors that we have. I would say that for those individuals who we really feel strongly are having focal seizures or partial onset seizures, the medication of choice usually is this medication, oxcarbazepine. And we choose it because it has in general, some of the fewest side effects, doesn't require a lot of lab monitoring, a lot of blood draws to look for abnormalities in kidney function or heart function or liver function. It comes in a lot of different formulations. It can come as a liquid or come as a tablet. And it usually is fairly effective for partial onset seizures. So that's often our first choice, but there are many other choices that you can see there. Next type of medication that we could potentially use is something called a benzodiazepine. This can be used for both partial onset seizures as well as generalized seizures. You might recognize some of these names, diazepam, midazolam, as medications that are used for what we call as an abortive. That is, individuals that are having a prolonged seizure can receive either a rectal diazepam, which is called Diastat, or nasal midazolam is now being used as an abortive, but not necessarily used on a daily basis, although in some cases it is. Clonazepam is another medication that I use fairly frequently, specifically for what we call bridging. This is an instance, for example, where an individual has seizures and is known to have worse seizures when they're ill with a common cold or the flu or something like that. So sometimes in those individuals, we'll provide clonazepam for 3 to 5 days to try to get them through that period where they're sick. And then clobazam, whose trade name is Onfi, is a medication that we do fairly frequently use on a daily basis, often for more generalized seizures, but could be used for partial onset seizures as well. Levetiracetam is another type of medication that we use for seizures. Again, it works fairly well for partial onset and generalized seizures, as well as for myoclonic seizures. Training for this is Keppra. There's a newer medication, brivaracetam or Briviact, which may be a little bit more efficacious, although I think it's probably fairly marginal, but it's just another tool that we have in our armamentarium. Keppra, in some ways we like it a lot because it does not interact with other medications really at all. It's cleared by the kidney. So in general, we don't have to worry about measuring blood levels of the medication or measuring blood levels of, or looking at liver function through blood or kidney function through blood. I will say there are quite a few kids who have taken levetiracetam and have had some significant behavioral side effects with it. Behavioral side effects are a known side effect for levetiracetam. And it's possible, at least, it seems in some kids with Phelan-McDermid syndrome, they're more sensitive to this. So there definitely should be some caution of starting levetiracetam with that regard. One of the newer medications that we have, or newer classes of medications we have, are glutamate receptor antagonists. And this really, at this point, includes just one medication, perampanel, that we can use both for partial onset as well as for generalized seizures. I will say I have not used this particularly much in kids with Phelan-McDermid syndrome, just because it's one of the newer medications. It, in general, can also have some of those behavioral side effects that's been seen in individuals who take this. I can't say that I've really seen that specifically with Phelan-McDermid syndrome, but certainly something to be aware of. And then another class of medications include topiramate and zonisamide. These kind of have multiple mechanisms of action, some sodium channel inhibition, as well as some glutamate receptor inhibition. It is efficacious for both partial onset, generalized seizures, as well as myoclonic seizures. These two medications are. Topiramate is usually given twice a day, zonisamide once a day. So one of the kind of benefits of zonisamide is you just have to give it once a day. In general, it only comes as a capsule. You can get it compounded into a liquid. And I do have some kids that take either zonisamide or topiramate with Phelan-McDermid syndrome. A couple of things to watch out for this medication. About 1% of individuals who take this develop kidney stones. This can be particularly problematic in kids with Phelan-McDermid syndrome because they can't really tell you if they're having pain associated with kidney stones. Usually when I prescribe it, I ask if either the child has a history of kidney stones, or if there's a strong family history of kidney stones, I'll shy away from this. But otherwise, potentially use it. The other issue with this medication is that it can prevent sweating. And this is already an issue in kids with Phelan-McDermid syndrome, so that has to be watched carefully. And I think this is the last medication I'll talk about, which is valproic acid. Valproic acid is one of our older medications, been around for, I guess now about 40, 50 years. Very good medication in preventing seizures, and it can be used for really any type of seizure, partial onset, myoclonic, generalized seizures, absent seizures. It works really well for that as well. Although it works really well for preventing seizures, there are lots of side effects associated with valproic acid. Weight gain is fairly common. Some increased hair growth is fairly common. We have to monitor very closely the blood level of the medication. Also look at blood production, because that can be inhibited. Different blood cell lines can be inhibited. And then also look for any signs of liver dysfunction. So usually we have to draw blood several times within the first 6 months of starting valproic acid. And once we're on a stable dose, draw blood about every 6 months or so to make sure there's no sign of liver dysfunction or inhibition of blood production. Oh, sorry, there's one more I'm going to talk about, which is cannabidiol. Trade name is for the FDA-approved medication Epidiolex. Primarily used in kids with Lennox-Gastaut syndrome. This is not a genetic disorder, but a kind of a constellation of seizure types. That's a really pretty devastating clinical disorder. And as I'll show you in a few slides, some kids with Phelan-McDermid syndrome are also diagnosed with Lennox-Gastaut syndrome. And then has also been approved for Dravet syndrome. Well, in addition to oral medications, there are other non-pharmacologic treatments for epilepsy. And I'll show you a few examples of that. One is vagus nerve stimulation. This is where a lead is implanted around the vagus nerve, which is a nerve found in the neck. And that lead goes to a generator, which is usually located under the skin in the chest wall. That generator fires at a pre-programmed rate with the pre-programmed amount of electricity going to the vagus nerve. It's thought that that stimulation goes back up to the brain, and somehow, I think we still really don't understand exactly how this works, but somehow can raise the seizure threshold to try to potentially prevent seizures. One of the other benefits of this particular device is that it can be activated using a magnet that's swiped over the generator, again, usually over the chest. And this will boost the amount of output to the vagus nerve in an individual that either appears to about to have a seizure or is actively having a seizure to try to abort it. Has variable efficacy, really depends on the individual. For some individuals, vagus nerve stimulators work great, really decrease seizure frequency and are great as an abortive. For other individuals, does not work as well. And our experience with vagus nerve stimulators, well, definitely used in some of my patients and others with seizures and Phelan-McDermid syndrome. We don't really have a definitive idea of how well it works in general in this population. A newer non-pharmacologic treatment is responsive neurostimulation. This is where a stimulator is implanted within the brain, within the skull, just outside of the brain. And this has two leads. One is a recording lead over an area that's been determined through epilepsy surgery to be a significant focus of seizure activity. And the stimulator can be programmed to identify when a seizure is about to occur and send a stimulation back to that area using the second lead to try to prevent the seizure from either occurring or abort it once it starts. I'm aware of maybe just one or two cases of kids with Phelan-McDermid syndrome, individuals with Phelan-McDermid syndrome who've had RNSs. There are probably more that I'm not aware of. It's certainly one of our newer non-pharmacologic techniques that is likely to gain more use in the years to come. And then we have surgical techniques to try to prevent seizure initiation or propagation. And this can frequently involve removing a portion of the brain that is epileptic. So in an individual who has frequent seizures, usually intractable seizures that aren't responsive to medication, through epilepsy mapping, we can determine if there is a single focus that is causing many or most of the seizures that the individual is having, and potentially remove that portion of the brain to prevent seizures from occurring. Typically, in an individual with a lot of seizures from one specific focus, that region of the brain is no longer connected normally, is not serving its normal function. So removing that portion of the brain will not have a significant impact on function of the individual. That certainly depends on the size of the region that's removed and the location of the region. So this is definitely done as a team approach between epileptologists, child neurologists or adult neurologists, neurosurgeons, and very frequently neuropsychologists as well. Another type of surgery that is sometimes used for intractable seizures is corpus callosotomy. This is basically where a highway between the two lobes of the brain, the left and right lobes of the brain, is disconnected. And the reason this is done is, in general, this is done in individuals where there is a focus of seizure activity in one area, but it rapidly goes to the other side of the brain, resulting in generalized seizures. The most common type of seizure in which this is implemented is for atonic seizures, although it can be used for other types of other seizure types, such as tonic seizures as well. Again, this is usually reserved for those individuals with what we call refractory epilepsy, meaning seizures that are not at all or not fully responsive to medications or other non-pharmacologic interventions. And then I believe this is the final non-pharmacologic intervention, which is the ketogenic diet. Some of you have probably heard of this. This is basically kind of akin to the Atkins diet, but a bit more restrictive. For the ketogenic diet, we really limit the percentage of the diet that contains carbohydrates to really as low as we can go. Here we say 5%, but we try to go as low as possible. So most of the energy is obtained from fat and some from protein. Very important, this should be done, if a ketogenic diet is tried in an individual, it must be done in consultation with an epileptologist that is familiar with the ketogenic diet, and usually in consultation with the dietitian. The ketogenic diet, once initiated, really needs to be monitored closely. We have to monitor for acidity of the blood, which is commonly happens, but we have to make sure that there's not too great a degree of acidity, and then also look at glucose levels, because in some individuals, the blood glucose levels can fall dramatically, and so that needs to be monitored as well. All right, so we're going to turn now to some of the life-threatening complications of epilepsy and seizures. One is status epilepticus. This is basically a state of recurring or continuing seizure activity in which a person does not return to their normal baseline. By definition, the oldest definition is that it's a seizure lasting more than 30 minutes, but in practice, we really define that as any seizure lasting longer than 5 minutes. So why are we so concerned about status? Well, there's some data, I'll say most of this is in adults, but some in children as well, that having a very prolonged seizure, so in this case, we're talking about a seizure greater than an hour, can lead to reduced survival. So you can see in this chart that survival for days after an episode of status that lasted more than an hour, those individuals with that seizure more than an hour, the survival at 30 days after the seizure was about 70%. And I will say this data, comes from all causes of status. So some of these individuals had bleeding in their brain or had a tumor in their brain that by itself probably led to some of the reduced survival. But we do know that these seizures that last longer than an hour can cause some damage to the brain itself. And so we certainly want to try to avoid this. And again, shown here, individuals that are much older, 80 years or older, are much more likely to pass away during or shortly after an episode of status. Again, this includes from all causes of seizure, such as bleeding in the brain or a tumor, which is why the mortality in those over 80 is so much greater. But you can see even in children, there is some degree of mortality associated with status epilepticus. Now, sudden unexpected death in epilepsy is a bit different. This is not where there's a prolonged seizure that's witnessed, but rather sudden death that occurs in an individual known to have epilepsy, but typically where a seizure is not witnessed. It can occur minutes to hours following a seizure. It seems to be a bit more prominent in adolescents and young adults. It is, as I'll show you in a minute, a very rare occurrence. So we don't have a lot of data regarding this and really have none regarding Phelan-McDermid syndrome, but something just to be aware of given how prevalent seizures are in Phelan-McDermid syndrome and the different types of seizures that are present. Seems to be more common in individuals with these generalized seizures. We don't, again, really know exactly why this occurs. It's thought that it might be due to some autonomic dysfunction in some individuals, leading to cardiac arrhythmias or apneas. But again, we don't usually discover exactly why this occurred. There's not, again, a lot of data regarding the incidence or the etiology of SUDEP. This is one paper with really a fairly small number of individuals, just showing that it can occur at most ages, seems to be a bit more prominent in adolescents and young adults. And again, as we already talked about, seems to be a bit more prevalent for individuals with generalized seizures. Okay, so what about seizures and epilepsy in Phelan-McDermid syndrome? So I will say this is still a bit of older data. There is some newer data, and I'll actually talk about some of that towards the end. But at the time I put these together, there were 12 retrospective studies describing the prevalence of seizures in individuals with Phelan-McDermid syndrome, with really a wide range of prevalence from 14% to 70%. I'll talk about one prospective study that's been done as part of the natural history study related to the RDCRN effort to characterize Phelan-McDermid syndrome. And in that study, they found a prevalence of 41% of individuals had a history of seizure. Detailed description of seizures, types, frequencies, and medications, and EEG abnormalities were only available in 2 studies at this point. There are more now, and I'll describe some of those in a bit. And then I'll talk about the natural history study, as I said. One of the first papers really to specifically look at seizures and EEG abnormalities in Phelan-McDermid syndrome was this one, which is a very small report of just 6 cases of Phelan-McDermid syndrome. In those 6 cases, 3 of those individuals had epilepsy. One of those individuals with epilepsy and what was described as Phelan-McDermid syndrome had a deletion that did not encompass SHANK3. Still a lot of controversy about whether this is Phelan-McDermid syndrome or not, but just to put that out there, that individual did not have a deletion encompassing SHANK3. Another individual in that cohort had a history of meningitis, which is an infection of the brain that can definitely predispose to seizures. So might have been independent of the Phelan-McDermid syndrome diagnosis. In that small group, those individuals had a relatively benign course, and they did find EEG abnormalities that primarily included what are called spike and wave abnormalities. These are abnormalities that really just predispose to having seizures. A publication by Sarasua et al. Demonstrated that it seems that seizure frequency increases in Phelan-McDermid syndrome with age. So you can see here that those children less than 5 years of age, only about 10% of them, had a history of seizure. Whereas if you go all the way to adults with Phelan-McDermid syndrome, over 60% of those had a history of seizure. So it does seem to increase with increasing age. So what has our experience been at Texas Children's Hospital? Well, we published a paper a number of years ago where we looked at our kids with Phelan-McDermid syndrome. At that time, were 24 kids, and 11 out of the 24 had at least one seizure during their lifetime. So that was a prevalence of 46%. Combining our data with all of the other data that was available at that point, we saw a prevalence of about 32%. And I think that's probably close to accurate. Probably about a third of kids with Phelan-McDermid syndrome at some point in their life will have a seizure. Doesn't mean all of those develop epilepsy. Sometimes they just have one seizure, sometimes only a couple associated with fever where we don't define it as epilepsy, but probably about a third will have a seizure at some point in their life. From our group, the average age of onset was 5 years with a range, a pretty broad range from 14 months to 14 years. Seizure burden was really all over the place. Some kids just had a history of one seizure. We had a couple that really had a high seizure burden of many per day. The most common seizure type that we saw was atypical absence. So clinically, these just look like absence seizures. We call them atypical. Can be a number of reasons, but usually it's because of the EEG pattern that we see. But despite this being the most common type that we saw, we also saw generalized tonic-clonic, atonic, myoclonic, focal, really the whole range of seizure types. 20% of our cohort at some point had a history of that status epilepticus as a seizure lasting longer than 5 minutes. And about 20% of the kids in our cohort had a diagnosis of Lennox-Gastaut syndrome, which again is this really profound seizure disorder associated with intractable epilepsy. In our group, we saw 2/3 of our kids had some sort of EEG abnormality. So again, that's greater than the percentage of individuals who had a diagnosis of a seizure at some point in their life, meaning that some of our kids do have EEG abnormalities without ever having a history of seizure, or at least to that point, not developing a seizure. The most common abnormality that we see is absence or slowing of the occipital dominant rhythm. This is just an electrical feature of the EEG that we can quantify, and is actually very commonly slow or absent in individuals with intellectual disability. We also saw irritability of the brain in terms of focal spike and wave or generalized spike and wave discharges. You see there in 38 and 19% of our kids. And again, we saw EEG abnormalities in many kids without a history of epilepsy. We did notice that individuals with multiple seizure types were more likely to have a slow occipital dominant rhythm. This is just an example of an EEG here, in case you've always wondered what does an EEG look like. So basically, you see a lot of squiggly lines here. On the left side of the panel, the first two kind of blocks here representing the first 10 seconds of this portion of the recording, what you see is very small amplitude but high frequency wave activity. This is actually pretty normal activity. This is what we hope all of our brain activities look like. And then in the middle part of this recording, what you can see is suddenly there's a high amplitude but much slower waveform, and this is an abnormal generalized epileptiform activity. I should mention in this individual, there was no change in their behavior. There was no clinical sign of a seizure. This just simply indicates irritability, brain irritability that can indicates this individual is predisposed to seizures. In general, we found no correlation between MRI abnormalities and seizures. There are kind of a spectrum of MRI abnormalities that have been seen in Phelan-McDermid syndrome, including some delayed white matter maturation, some abnormalities of this corpus callosum, this white matter tract that connects the two sides of the brain. But none of these are really specifically associated with seizure activity. The patients that we see have been and continue to be prescribed all sorts of different anticonvulsant medications, none with clear superiority. We had a couple of kids with vagus nerve stimulator with some improvement in seizure burden. that can certainly wax and wane with time. And we had one individual who had a corpus callosotomy for those severe, medically intractable drop attacks with some improvement in them. So as I mentioned, there's been one study, one prospective study looking at looking at EEG and seizures in Phelan-McDermid syndrome, and specifically looking at what is the efficacy, what is the benefit of long-term EEG, that is recording an EEG over days instead of just a brief 30-minute EEG. So in that study, there were 16 participants. A little bit more than a third had a history of epilepsy. Most of those individuals had generalized slowing of that occipital dominant rhythm. Only 25% had seizure activity on routine EEG. Again, that's that brief 30-minute to 45-minute EEG, whereas 75% had abnormalities when the EEG was extended to overnight. However, no seizures were recorded during any of those EEGs. One thing that they did identify through the study was that during sleep, there seemed to be more of these epileptiform discharges than during wakefulness. And the example they gave is just shown here, where on the right is the recording from a child when they're asleep. And you can see in that red box, the high amplitude, low frequency activity that's generalized, indicating a predisposition to seizures. So finally, I'm going to end with a discussion of the genetics of epilepsy and Phelan-McDermid syndrome. Before I even get to that, I'll just say that we still really don't fully understand the genetics of epilepsy and Phelan-McDermid syndrome. Most of you have probably heard of the SHANK3 gene. We think that the mutation of the SHANK3 gene, loss of one copy of the SHANK3 gene, causes many, if not most, of the symptoms associated with Phelan-McDermid syndrome. And in this study, which we participated in with Alex Collison, we found that out of 17 individuals with a point mutation that only impacted SHANK3, 5 of those individuals, so about a third, had a history of seizure at some point in their life. And compared to one of the publications describing, one of the largest publications describing deletions involving the SHANK3 gene, it was about 40%. So it's actually fairly close, maybe a little bit less common in the kids with SHANK3 mutations, but again, the numbers were fairly small. A more recent study has suggested that perhaps there are other genes other than SHANK3 that are important for seizures in Phelan-McDermid syndrome. So in this study, what they found was that in individuals with deletions that were fairly large, that involved more than 4 million bases, included SHANK3, but many, many other genes, that 70% of those individuals had a history of seizures. And they compared that to individuals in their cohort who had a deletion less than 4 million base pairs. And what they found in those individuals, only 16% of them had seizures. So that would suggest that there are other genes that are, other than SHANK3, that are important for development of seizures and epilepsy. However, in the same study, they also had 10 individuals with point mutations just in SHANK3, and 7 out of 10 had a history of seizures. So the data is a little bit conflicting. What I would say we can take away from all of the data at this point is that probably having a mutation, having a loss of function mutation in SHANK3 does predispose to development of seizures. There are potentially other genes in individuals with large deletions involving SHANK3, but many other genes that can also impact whether an individual develops seizures, but there's still more work to be done in this regard. And then I'm going to end just with this slide. This is some work that was done by the Rare Epilepsy Network, which some of you may be involved with. And basically in this study, they looked at a number of genetic disorders and asked, in these disorders, in individuals with a history of epilepsy, what other comorbidities or other symptoms are associated with epilepsy in these kids. And so I'll just point you to the third column to the right here, which is Phelan-McDermid syndrome. Again, a relatively small number of individuals participated, only 29. But what we see is in this cohort, the most common comorbidity or symptom associated with epilepsy was learning and developmental disability, not unexpected for Phelan-McDermid syndrome and what many other studies have found. The second most common issue were mental health or behavioral issues, and followed closely by sleep disorders. Again, all things that parents deal with every day who have children with Phelan-McDermid syndrome, and things that had been seen before. But this was just put in the context of other genetic disorders associated with epilepsy. And then I'll just point you all to the practice parameters for Phelan-McDermid syndrome. They're available through the Phelan-McDermid Syndrome Foundation website. These are being revised right now. Hopefully that work's going to be done fairly soon and published. I would say for neurology, I don't think things have changed all that much in terms of what we're going to recommend. For kids that have that develop seizures and epilepsy, we're going to recommend an EEG be done. Perhaps changing a bit from recommending an overnight EEG to first starting with a brief 30 to 45 minute EEG, depending on the results of that, then progressing to an overnight EEG. And that's going to be followed with MRI to look for structural changes that might predispose to seizures. And then, I didn't talk about these other areas of neurology, but issues with motor skill development or hypotonia would warrant evaluation and treatment by occupational and physical therapists. And feeding difficulties should be evaluated by a feeding therapy specialist. So I'll end there. The work that I presented from our group was driven largely by myself and Michael Quash, who's a neurophysiologist with our group, who helped me with characterizing epilepsy and EEG abnormalities in our kids. And I'll end there and take a look at the questions that have come up. Thank you so much.
Thank you, Dr. Holder. Both want to show our gratitude to you for this presentation and the families who have joined us. We also have a sponsor message to share. And if you don't mind delaying answering the questions just for a bit so we could share that, because this wouldn't be possible without our sponsors doing these webinars. And then if you need us to pop your slides back up to facilitate any questions, we would be happy to do that.
Our mission at Jaguar is to accelerate breakthroughs in gene therapy for patients with severe genetic diseases.
With gene therapy, we can give the opportunity at a better life. That's what makes Jaguar special.
So nice and quick. And then we do have some questions. I want to remind the families who asked these that Dr. Holder is unable to provide medical advice. So most of them came in very general. Some of them are specific to their children. So his answers are going to come back as general, just so that you know that. But I'm going to provide them as they came in. The first one was related to the medication. Can any of these anti-epileptic drugs that you shared impact the ability for the children to learn?
It's a great question. And yes, they can in two different ways. So in one way, a child that's having very frequent seizures, that will by itself impair learning. So suppressing those seizures can actually enhance learning through whatever mechanism you decrease seizure frequency. Now, on the other hand, some of these medications are known to impact learning and memory. And I won't go into specifics of any given one, talk to your neurologist about that, but there are some that in neurotypical individuals are known to have some impact in learning and memory, some negative impact in learning and memory. So it is definitely always a balancing act. Having lots of seizures every day for anybody is going to impair their learning, but medications can have side effects as well. So great question.
It's a difficult balance for our epileptologists to manage, especially with these rare epilepsy kids. This next one describes their daughter's challenges a bit. My daughter has some myoclonic and atonic seizures. It happens frequently, and she has an atonic seizure followed immediately by a bowel movement. We're wondering about the potential connection between the seizures and bowel movements.
Yeah, that's an interesting question. It's one that we actually see fairly frequently. I will say loss of continence, so either urination or defecation. I will say happens more frequently with more prolonged seizures, so those grand mal type seizures. A bit unusual after an atonic seizure because they are so brief, but I think that there probably is a connection there.
Um, Again, and nothing to worry about, I think, incontinence with seizures in general.
Oh, right,
And I
right.
mean, that's
Yeah, I should absolutely say that, but it's very common and nothing specifically more to be done because there's incontinence after a seizure.
what behavioral side effects, as you had mentioned them with levetiracetam, should the parents be aware of? Should they be watching for and maybe advocate for their child if they're seeing behavioral, dissecting between behavioral issues that you might see in a PMS child and then additional behavioral issues that while they're on levetiracetam?
Yeah, it's very difficult, right? It can be very difficult to distinguish those. And it's something that, I potentially struggle with all the time. I would say that where I feel very confident that there was an issue is when we start a medication and then within a couple of days, behavior has dramatically changed. Usually it's irritability, it's increased behavioral outbursts, things like that, that we would potentially look for. In particular for levetiracetam, there is a vitamin that we can try. Sometimes it works okay in terms of improving behavior after starting levetiracetam, sometimes not. So it's definitely worth a try if your child is on that medication. But really, it's just, in general, it's increased irritability and more behavioral outbursts.
This parent had a question about VNS and had heard about an alternate VNS device that are not surgically implanted invasively, but rather that attach to the back of the ear. Is there any evidence of this being used in epilepsy and having an effect?
I am completely unaware of this device. I'll have to do some research myself. I don't know about this one.
All right. Have you had any experience with clinically apparent atonic seizures without a corresponding EEG signature? And they go on to say, sudden transient loss of tone that is perhaps not epileptic in a PMS Lennox-Gastaut patient.
So I can't say that I have specifically for atonic seizures. I can be a little bit more general and say that one of the disadvantages of how we perform EEGs is that the leads, what they're called, which are just the wires that connect all over the scalp, are only on the scalp. So it is possible for there to be deeper abnormalities, so abnormalities deep within the brain that are not picked up by those scalp EEGs. There are alternative ways of trying to identify those. One is through a device called a magnetoencephalogram, a MEG. So that uses really a kind of a more complex magnetic field to measure activity, not just on the surface, but also deeper. And there's some other subtleties of how it works as well. Those can be challenging a number of reasons. They're not as widely available. Really large academic centers will have them, but that's pretty much it. The other challenge is kids have to hold fairly still during that recording. So although here at TCH, we do MEG recordings from kids with significant developmental delays and behavioral issues, but it's just a bit more challenging.
Well, and you presented, and so this is sort of piggybacking on this question. Another parent asked a question. So the standard of care, a child who presents with a seizure would then have the EEGs. This parent asked, in the study you mentioned, where the kids whose EEGs showed slowing and epileptiform discharges, were they diagnosed with epilepsy? And they were curious if individuals with PMS can have EEG abnormalities but are not diagnosed with epilepsy. So sort of the chicken and egg issue, could we have children with PMS with these subtle seizures and not know it?
Absolutely.
Because,
Yeah, absolutely. So still at this point, the diagnosis of epilepsy is a clinical one, meaning based upon clinically obvious seizures. Now, there are some, that's not 100% the case, because if we record a prolonged abnormality on EEG, and that's an abnormality lasting more than 10 seconds, we will call that an electrographic seizure, meaning this child has had a seizure based on EEG, even if there aren't obvious clinical signs. And it's a good point that in Phelan-McDermid syndrome, it's maybe more possible that a child will have a seizure that's not clinically apparent, and they cannot tell you that they feel something different, or it may not be obvious that their behavior has changed. Because kids with developmental delay in general, and Phelan-McDermid syndrome in particular, will very frequently have staring spells that are not epileptic. They're just inattentive. I will say, for the examples I showed, those very brief discharges, we would not diagnose epilepsy based on that, if that's the only thing that we saw. But if there's a prolonged abnormality, or there is at least one clinical seizure and a lot of those abnormalities on EEG, then we might go ahead and diagnose epilepsy. On the flip side, there are definitely kids with Phelan-McDermid syndrome who have EEG abnormalities, whatever those might be. I gave a couple examples of what they could be, and they do not have epilepsy. And it's a great question, like what impact does that have on their development? It's something we really don't know at this point.
That's the value of the RDCRN and those natural history studies, is that they enroll and they have the EEGs because they're part of those studies, and then you see these abnormalities and you can correlate them with some of these other tests that you're doing that are related to development. This parent asked something that's very specific to their child. My son had many complex partials at age 6, where he stopped breathing for up to a minute. After several seizures, we were able to stop them with medication, but he lost all fine motor skills after this, roughly for 2 months of weekly seizures. Some were regained, but not all. And is this explained by the severity of the seizures, possibly causing the damage?
Yeah, it's an important question. Unfortunately, I'm not going to be able to give you a specific answer because we don't know, is the short answer. We have some evidence in general that really long seizures, meaning again, those seizures that last more than 30 minutes or more than an hour, can cause damage that we can see through things like MRI. Briefer seizures lasting up to a minute or even up to 5 minutes, we usually don't see any damage on the techniques that we have available for imaging, like MRI. Whether there's some change with brain function or brain structure, we really don't know very well. I will say this is not uncommon for Phelan-McDermid syndrome to hear that a child suddenly has onset of seizure and some regression of skills associated with that. Again, one of the important reasons to try as best you can to get them treated as early as possible. But I will say we don't know for sure that there's a correlation or there's a causation. I guess we can say there's a correlation, but we can't say for sure that the seizures caused the regression, or did they just happen at the same time because the same process caused both of them.
And this is one of my favorite questions because I think it occurs in a lot of our rare epilepsies, and it's a challenge for clinical trials. Is it common to see multiple types of seizures in Phelan-McDermid syndrome?
Yes, absolutely. Definitely have some kids that have really all of the seizure types that I described today. And then some kids only have one, or the majority actually have none. So yes, all of those are possible.
And this is just my curiosity. Have you had good validation between, or found good standard ways of validating between parents and investigators what type of
Mm.
seizure your child is having, because then as you have to record them in diaries and do those sorts of things to get towards a
Yeah,
therapy, that becomes a challenge.
exactly. That's a really great point. One of the ways that we try to do this is to ask parents to shoot a video
Mhm.
with their phone if they can. And I really should add that probably to my workup, because that's pretty standard that we ask parents, if you can. Obviously, lots of reasons that it can be difficult. They can be very short, so it's hard to get the phone before the seizure's over. In a child that's suddenly having new seizures, it's very traumatic, and to ask a parent, hey, you have to calm down and try to find your phone. That's really difficult stuff. So there can be lots of obstacles to getting that, but that can be very, very helpful in terms of really deciding if events are seizures, and then if they are seizures, what type of seizures they are.
I think I had one question: is vomiting common after giving the nasal emergency spray to the child to stop a seizure?
Yeah, so I will say vomiting after a seizure is very common. And whether it's just because the seizure stopped or because of the medication itself, I think it could be either.
Right.
But vomiting after a seizure is very, very common.
And I think that's not necessarily, like you were talking about correlation and causation. It's hard to be able to tell whether it was administering the recovery drug, or I think seizures oftentimes, as a person with epilepsy, that guttural it can happen, and
Right.
that's not something, as a caregiver, that's an empowerment thing, I think, to be able to give the
Yes.
rescue med, right, or to
Absolutely.
use the magnet with the VNS.
Right.
And so to not let that stop you if the patient has sort of an adverse effect.
Absolutely. And in this talk, I didn't go over seizure precautions, but one thing to be aware of is if your child is having seizures, it's always a good idea to turn their head to the side so that if they do vomit, which is very common, they don't inhale that vomit back in. So have their head kind of tilted to the side, and never put anything in their mouth. They will not bite their tongue off or swallow their tongue or anything like that. So keep their mouth free of any foreign objects.
Have you seen prolonged post-ictal periods in the PMS population?
Yeah, that's a great question. I'm trying to think if I have. I would say in general, definitely possible. I don't know if I've specifically seen that or not. I can't recall seeing that. But certainly possible. I would say more likely with a longer seizure. And by longer, I mean, 5 minutes would be long enough to have a fairly prolonged postictal state. In general, very brief ones like 10, 15 seconds, you're less likely to have that prolonged postictal state. Like I said, I can't say that I've seen that specifically, but it would not be unexpected at all.
So that if a parent was to have a child that just the day after was very tired, and it's hard to say that was that seizure if it wasn't a tonic-clonic type seizure or a long seizure. In this population, you wouldn't relate it to this population per se, or the seizure type that could happen in epilepsy in general.
Yes,
right?
Right. Absolutely. Absolutely. And I guess postictal states can look like a lot of different things. The most common definitely is being very tired, not behaving normally. Very, very common. And if that happens for 1 or several hours after the seizure, completely expected. If a child has several seizures in one day, that could last even longer, even into the next day. Another type of postictal finding that we can see sometimes is called a Todd's paralysis. This is where part of the body isn't working as well, almost looks paralyzed. I would say that if your child has that for the first time, you should take them to the emergency room, because there are other things that can cause both a seizure and paralysis, and the main thing being a stroke. Stroke is not more common, as far as I know, in kids with Phelan-McDermid syndrome, but stroke in general is on the rise in children. So if you were to see that for the first time, definitely take them to the emergency room to be evaluated. If you work with an epileptologist or child neurologist for a while and realize that every time your child has a seizure, they have some weakness on one side, you might not need to take them every time, but absolutely, if it's the first time, either they've ever had a seizure or the first time had a seizure and then had paralysis on one side of the body or the other, take them to the emergency room.
Wonderful. Yes. All the things we need to keep an eye out for. And I have one last question, but I think we get them trickling in here at the end. Is there any way to have a consultation from another country? If one of our PMS members, family members, gets in touch with the PMS, executive director or Dr. Kate Still, is there a willingness there? Or
for me in particular?
Yeah, I'm guessing that's what they're
so.
asking.
I'm always happy to talk to physicians, and I have talked to physicians from all over the world. I think that's potentially the best way, because I could not provide any specific medical advice to an individual, but I could definitely talk to a colleague neurologist about issues. If it's about seizures, if it's about something more general with Phelan-McDermid syndrome, and especially neuropsychiatric issues, we do have the ECHO group. It was already brought up, and I would definitely, and we take consultations from all over the world, so that's definitely an option. But if there's a specific question about epilepsy, I'm happy to discuss it with anyone's doctor.
And that's so that families understand that's a doctor to doctor situation, where if they're your physician in your country, then could potentially he would be happy to discuss epilepsy treatment with your doctor in your country.
Absolutely. Yep.
I don't see any other questions at this time.
Okay.
So thank you so much for spending your time with us today.
Absolutely.
And
thank you all.
thank you to the families for joining us. This has been really wonderful to learn about seizures and Phelan-McDermid syndrome.
All right. Thank you.
All right. Take care.